Good morning, everybody. I'm Dr. Nirmala Jambhekar, and going to talk to you on immunohistochemistry in orthopedic oncopathology. So, the outline of my presentation is what is immunohistochemistry, what type of specimens are required for testing, what are the limitations, and what is the role of immunohistochemistry in bone tumors, in soft tissue tumors, and towards the end, some insight into new markers for bone tumors and soft tissue tumors. IHC was first introduced in 1970, subsequent to the discovery of monoclonal antibodies and the application of the knowledge that all tissues have proteins which are the antigens, and these can be detected in histology sections by way of immunohistochemistry, and this knowledge gave a tremendous boost to the diagnostic skill of the pathologist. The advantage of immunohistochemistry is it is an extension of the routine H&E procedure. No separate gadgetry is needed, and the slides can be examined on the routine microscope. Another big advantage is it can be done on samples in the paraffin blocks, and most pathology departments store paraffin blocks for a variable period of time. So, what is immunohistochemistry? It is basically a slide based chemistry. The reaction is between the antigens, which are inherently present in tissues, and a commercial antibody known generally as monoclonal antibody. Now, this commercial antibody is tagged with a chemical which is the one which is usually used is known as DAB, and the final reaction which one gets is a brown color. So the end result, if the reaction is positive, is to look for the brown color. Now, this is a schematic representation of the immunohistochemistry procedure. The proteins are present in fixed tissues, and these are made to react with antibodies which are tagged with a coloring colored product. So, if there is an antibody reaction, or if there is an antibody which reacts with the protein in the tissue, the end result is brown color. Now, this is an article which I wrote more than 10 years ago, but it is still relevant to some extent. And the title is Immunohistochemistry, a simple, powerful, yet complex tool. And why is IHC simple? Because it can be done in any lab, and it is an extension of the lab procedure which I just mentioned. And it is powerful because in many situations it helps confirm a diagnosis which is not very clear but only suspected on H&E. It helps to sort out the various differential diagnostic considerations, and it helps to pinpoint the primary in metastatic disease from an unknown site. So, what then are the significant points to remember? It's obvious that different tissues in the body have different kinds of antigens, and these are not only in different organs, but these antigens are seen in the different constituents of the body cells. Some of these antigens are present in the cell membrane, some are located in the cytoplasm, some are seen in the nuclei, and some are the products formed by the cells, and for example, the hormones. Now, not only that, the antigens in the cells, the various cells of the body, also vary depending on the stage of evolution of the cell. For example, a mesenchymal cell in its very primitive form will show a marker called vimentin, But suppose that cell is destined to become a muscle cell, then it gets on proteins which are known as desmin and myoglobin. In fact, lymphocytes are cells which are very immunogenic naturally, and hence they show a variety of markers depending on the stage of their natural evolution, proliferation, and progression, not only during normal development but also during tumorogenesis. Now, some proteins are unique to some cell constituents, whereas many others have common shared epitopes, meaning some of the antigens are not unique to a cell or a tissue. They can be found in different kinds of tissues and different kinds of cells. So it is necessary that before requesting a immunohistochemistry, the basic H&E section needs to be evaluated to come to a tentative or a working diagnosis before the request for IHC is put. For example, now this is a case of Ewing's tumor, and these are the small round cells which are so very uniform. And the stain which has been used over here is known as MYC2 or CD99. This is the monoclonal antibody or the marker. And if you look carefully, the brown color is seen at the periphery of the cells. So it is what is known as membrane staining. Now this pattern of staining in the membrane with MYC2 is very important to make a diagnosis of Ewing's sarcoma. The reason is MYC2 or CD99 is positive not only in Ewing's sarcoma, it is also positive in synovial sarcoma, which is a soft tissue tumor, and it is also positive in lymphoblastic lymphomas, the T lymphoblastic lymphomas. And the pattern of reaction is different in each of these. This, of course, is not the complete list of tumors where CD99 comes positive. So the pattern of reaction in every tumor and in every scenario is different, and this knowledge is extremely important to make a correct interpretation after having done the IHC test. So interpretation requires not only the correct scenario, since shared epitopes are so widespread, clinical information is extremely important. So interpretation is just not looking at some brown color anywhere in the section. It is much more complex. Now, what are these monoclonal antibodies? Broadly speaking, the monoclonal antibodies, for which henceforth I'll use the term as markers, they can be designated depending on the predominant tissue which they normally stain. So there are markers which are known as epithelial markers, mesenchymal markers, lymphocyte markers, markers for cell proliferation. Ki67, you must have heard this, or MIB1 is a marker for cell proliferation. Markers for hormones, the ER-PR receptors, which are utilized in cases of breast cancer, actually look for hormones. Now, these are all the products which are formed by the cells, but the newer markers or the modern markers are targeted towards the product formed by the specific genetic alteration, and hence they are a good surrogate to identify the presence or absence of the genetic abnormality. For example, Ewing sarcoma has EWS Fly1 rearrangement. So you can have markers to identify the rearrangement and not specifically the product which is formed. So too SSX SYT in synovial sarcomas and so on, many other tumors which have specific molecular signatures can be investigated with the help of certain monoclonal markers which target the genetic abnormality or which identify the genetic abnormality. So, what are the limitations of IHC? The limitations are pre-analytical, analytical, and post-analytical. By pre-analytical, what we mean is before doing the actual IHC test. So, the most important factor is good and prompt fixation in 10% buffered formalin for 6 to 8 hours is a must. It is essential for small biopsies. Now, very often biopsies are now put in normal saline or they just left to dry. This has very deleterious effects because the antigen which we will be trying to seek in the tissue leaches out and then one doesn't get good results. So ideally for small biopsy the fixation should be 6 to 8 hours, and if the specimen is larger it can vary anywhere from 12 to 18 hours. The second step with regard to analytical limitations is the pathologist has to judiciously choose the correct antibody to corroborate the diagnosis, and this has to be followed by the correct interpretation. So as I said, any brown color in the slide is not good enough. The color has to highlight the expected cell and the expected part of the cell in the slide. Now, what about post-analytical? Now, quality, there are so many monoclonal antibodies, and most laboratories do this procedure by hand, and there can be variations in the staining, partly due to human errors and partly due to the not making the correct dilution of the antibody. So quality control to ensure the integrity of the monoclonal antibody and the preparation of the slide are very important, and hence participation in quality assurance programs helps to ensure quality in the IHC labs and the IHC procedure. Now, as far as bone is concerned, there's a big limitation. Strong acids which we use for decalcification of bony tissue destroys the antigen in the tissues, and hence one has to be very careful about the percentage of the acid which is used for decalcification, and one should monitor this, not put the tissue in the decalcifying agent and forget about it. Another limitation is prolonged fixation. If the tissue has been pickled in formalin for a very long time, certain scum-like products form on the surface of the tissue and with the help of formalin. Now this masks the antigen. Of course, there are methods inherent in the IHC procedure known as antigen retrieval methods, which are in fact routinely used to unmask the antigens from the tissues. Now, I said in the beginning that old paraffin blocks can be used. Yes, they can be used, but they need to be preserved properly in the correct with the correct temperature and the correct humidity, and they are a great source for scientific research. So, IHC is simple, it is powerful, but yet in many ways it's also a complex tool. Now, what is the role of IHC in bone tumors? It is most useful in the differential diagnosis of malignant round cell tumor, and we know that Ewing's is a malignant round cell tumor which can mimic lymphomas, it can mimic rhabdomyosarcomas, it can mimic mesenchymal chondrosarcoma. So all cells which have small round blue, all tumors which have small round blue cells. Now, IHC has very limited role in bone forming tumors like osteosarcomas. There isn't a very satisfactory monoclonal antibody which can help differentiate a parosteal osteosarcoma from other surface tumors, or in bone forming tumors which are, say, osteoblastoma, osteosarcoma, fibrous dysplasias, etc. Uh, we don't have good stains which can differentiate these entities in the bone forming lesions. Now, as far as cartilage tumors is concerned, yes, there is a role in cartilage forming tumors that also has been discovered only of late, and IDH1 is a marker which is used to differentiate chondroid tumors and chondrosarcomas, which often is a big diagnostic issue. Then H3F3B is a marker which is used to diagnose chondroblastomas of bone, and more recently there is a marker called GRM1 which is useful in making a diagnosis of chondromyxoid fibromas. Now we know that the most common bone tumor is not Ewing's or osteosarcoma or chondrosarcoma. The most common bone tumor is a metastatic tumor. The malignant bone tumor, are metastatic tumors. Now, very often patients come with a lesion, elderly patients come with a lesion in the spine or in the hip, and they have a destructive lesion. And then when a biopsy is done, you find that it is a carcinoma. Now, most adenocarcinomas look like one another, or they look like each other, and the pathologists can help to some extent in pinpointing the probable site of the primary from where this tumor has arisen in the first place. As regards soft tissue tumors, the role of IHC in soft tissue tumor is much more pronounced, and it is useful in almost each and every soft tissue tumor. And as we know, soft tissue tumors can be categorized into different, broadly categorized into different types of cells, like those which show round cells, those which show spindle cells, pleomorphic cell, epithelioid cell, etc. The advantage of doing IHC in soft tissue tumors is these tumors do not need any decalcification. Hence, their antigenicity is much more better preserved than it is in the hard bone tissues. Now, today we know the list of molecular abnormalities described in various tumors, especially the soft tissue tumors, has been ever increasing, and the protein product accumulating in the cell due to this abnormality can be tested with the help of immunohistochemistry. Hence, the utility of IHC for soft tissues sarcomas is much more pronounced and has made much more rapid strides. Now let me give you a few examples of giant cell tumor, ABC, Ewing's, metastatic tumors and soft tissue tumors. Now this is a 31-year-old male who has a lesion in the upper end of the humerus. As you can see, there is a lytic lesion with a path fracture. There isn't much periosteal reaction. The margin with the host bone is well defined, but there is no sclerosis. And the lesion extends right up to the end of the bone, articular cartilage. So yes, radiologically one can call it a giant cell tumor. It's a skeletally mature patient. And on the right hand side, you see a typical giant cell tumor where you have this multinucleate osteoclastic giant cells and spindle cells. Now, until recently, the diagnosis of giant cell tumor was made on the basis of clinical, radiological and routine H&E sections. But we know that there are several lesions which are rich in giant cells, and differentiating a true giant cell tumor from, say, an aneurysmal bone cyst, sometimes a telangiectatic osteosarcoma, can be very, very tough. And the list of lesions with giant cells is shown in this slide, and the list is incomplete. But just to run through all the names, numerous giant cells are seen in giant cell tumor, ABC, chondroblastoma, benign fibrous histosarcoma, and of course giant cell rich osteosarcomas. Comparatively, fewer giant cells are seen in chondromyxoid fibromas, and a variable number are seen in tuberculosis and Langerhans cell histiocytosis. Now coming to metabolic lesion, brown tumors of hyperthyroidism can have innumerable giant cells and mimic a true giant cell tumor very, very closely. Then we have giant cell tumor of Paget's. So traditional teaching has been to look at the age, sex, location in the bone, radiological images, biochemical parameters, etc., and make a diagnosis. Today we have a marker for the spindle cells seen in a giant cell tumor, and this helps us to make a confident diagnosis of a giant cell tumor. And the monoclonal antibody which is used is known as H3.3P G34W. Now, if the tissue reacts with this monoclonal antibody or this marker, we know that yes, this is indeed a true giant cell tumor and not its mimic. Here is a case of a 13-year-old male patient with a lesion in the upper end of the humerus, and you can see there's a huge lesion in the metaphysis not going up to the end of the bone, and there is a smooth periosteal reaction. It is unlikely to be a giant cell tumor because the patient is not skeletally mature, and also because of this radiology. Now look at the histology section. In the upper half, you see numerous giant cells so similar to the giant cell tumor, and in the lower half, you see abundant blood in these so-called spaces. So this is actually an aneurysmal bone cyst. So the differential diagnosis of aneurysmal bone cyst is giant cell tumor, but also chondroblastoma. So the diagnostic molecular abnormality in ABC is known as the USP6 gene arrangement. For a long time, ABCs were considered as tumor-like lesions, but today they are considered as tumors. Now this abnormality presently is detected only with the help of a technique called FISH, which is fluorescent in situ hybridization. But it is quite likely that in the coming years we will find, or there will be, a USP6 antibody, monoclonal antibody, which can help confirm the diagnosis of ABC on a routine microscope with the help of routine immunohistochemistry. Now, just like giant cell tumors have H3.3 antibody, there is a near close monoclonal antibody, but it's a different clone. It is known as H3F3B. Now, this antibody or this marker is found in chondroblastomas. So, immunohistochemistry not only helps to distinguish ABC from giant cell tumor and chondroblastoma, it also helps to distinguish a giant cell tumor and a chondroblastoma, because chondroblastomas also have lot of giant cells. Now let's look at this other case, 12-year-old male patient with a lesion in the lower limb. So what you are seeing, the lesion is probably in the bone, spilling over into the soft tissue, but the biopsy shows a tumor with uniform rounded cells, and there are a few capillaries running in between. Now when we encounter a lesion like this, there is a very wide list of differential diagnoses, and they come under the category of malignant round cell tumors, and the differential diagnosis can be Ewing sarcoma. The term PNET is no longer used. The differential diagnosis includes rhabdomyosarcoma. It includes a tumor called desmoplastic small round cell tumor, which generally occurs in pediatric age group in the thoracic soft tissue. The differential diagnosis can be neuroblastoma. The differential diagnosis can be lymphoma, and in fact we recently saw a case where the differential diagnosis was in fact a retinoblastoma, which had been operated many years ago when the patient was an infant. So in such an instance, IHC is extremely useful. So I showed you how Ewing's is positive for MYC2 or CD99. So here we see in the lower left hand corner a strongly MYC2 positive tumor, and we know that this is a Ewing's tumor. On the right hand side you see a marker called vimentin. This marker is not so specific because it is found in all mesenchymal cells, like in muscle cells, it can be found in nerve cells, it can be found in most tumors. So vimentin is not a specific immunohistochemistry marker, unlike MYC2, which has a much more significant role to play in making a diagnosis of not only Ewing's but several other tumors which can also be positive for MYC2. And I did mention about shared epitopes between various tumors. Now look at this 65-year-old female who has a lesion in the hip bone. It looks osteoblastic. Now in a woman of that age, the first thought which would come to your mind is not an osteosarcoma, despite the lesion being an osteoblastic lesion. The first thought which would come to your mind is metastatic deposits. And yes, the slide on the right shows a tumor which is high grade, and it is a poorly differentiated adenocarcinoma. So it is indeed metastasis of adenocarcinoma, but when the patient came to the orthopedic surgeon, there was no history of any other lesion anywhere, so it was metastasis from unknown primary. So what the pathologist has done is used two markers CK7 and TTF1, and the coordinate expression of these markers, meaning the tumor is positive for CK7, which is seen in the cytoplasm, and hence you have that honeycomb-like appearance in the CK7 slide. And it is also positive to a marker called thyroid transcription factor 1, which is seen in cells which come from the lung alveolar lining. So the presence of these two markers make it quite certain that this patient has an adenocarcinoma in the lung, which was not suspected initially, and subsequent to the diagnosis, one can do the relevant imaging to hone down or pinpoint the primary tumor. Now, the diagnosis of soft tissue tumors, as I said, often requires immunohistochemistry. Now, broadly speaking, soft tissue tumors are divided into four categories, like spindle cell and epithelioid cell sarcomas, the round cell sarcomas, which occur both in the bone and in the soft tissue, the tumors which have a lot of myxoid component, like the myxoid liposarcomas, myxoid nerve sheath tumor, and pleomorphic sarcomas, wherein the tumors have very pleomorphic cells. Now, within each of these categories, A, B, C, D, there are several other entities. For example, in category A, that is spindle and epithelioid cell sarcomas, the entities which can be included are synovial sarcoma, leiomyosarcoma, neurogenic sarcoma, angiosarcoma, GIST, PICOMA, epithelioid sarcoma, and the list is not yet complete. So how does a pathologist go about identifying each of these tumors? After seeing the H&E slide, the pathologist makes a tentative diagnosis, and then the antibodies are judicially selected depending on the tentative diagnosis. So if he suspects that it is a muscle tumor, he may do SMA, HCAL-Desmon. If he feels it's a nerve sheath tumor, he'll do S100. If he feels it's a vascular tumor, he'll do the CD31, 34. And there are hundreds of such monoclonal antibodies which are available. And the most limiting factor for any laboratory is the expense. So if you don't have a turnaround of several tumors, then having the uncommon monoclonal antibodies or markers does not work out to be cost effective. So this is an example of a synovial sarcoma, a blue colored tumor. It's a mesenchymal spindle cell sarcoma, and we all know that this has a specific chromosomal translocation TX18 and P11QL. Synovial sarcoma IHC panel requires at least 2 to 4 stains, and here we have CK7, CK19, and you will see CK is cytokeratin, and cytokeratin is an epithelial marker. But yes, soft tissue sarcomas, which are actually not epithelial tumors, can also show epithelial markers, and this can be used to our advantage to make a diagnosis. And this is epithelial membrane antigen, which is also seen to some extent in synovial sarcoma. But a more specific marker is this TFE3, which is seen in synovial sarcomas. So to make a diagnosis of a single tumor, very often it's not just about using one stain and saying this is positive, so okay, that is a diagnosis. You often need to use a panel of IHC stains to substantiate the diagnosis. So to summarize my talk of IHC in bone and soft tissue sarcomas, it helps diagnosis and it helps initiate correct treatment. Now, is IHC needed in every soft tissue tumor, every bone tumor? Not at all. IHC is not needed in each and every case, and it is not relevant, and there are no available antibodies for every tumor which has been described in the WHO books. Now, the first important basic step before doing IHC is the HNE has to be looked after carefully, and the differential diagnosis is important because that is how one will select the immunostains. So, in the differential diagnosis, one of the answers has to be correct, because if that is not included, then the pathologist is running wrong antibodies, and just by doing immunohistochemistry, one is not going to get an answer or the final diagnosis. Now, to interpret immunohistochemistry, knowledge regarding sensitivity of the antibodies, specificity, knowledge about shared epitopes, aberrant expression is all very vital. In addition to that, the pattern of staining, is it in the cytoplasm, the membrane, the nucleus, that also is important, and it is important to keep abreast of this IHC knowledge, because new markers keep on evolving and it is indeed a dynamic field. And as regards bone tumors, the role of IHC is relatively limited but very useful in Ewing sarcomas, giant cell tumor, chondroblastoma, ABC, osteoblastoma, whereas in soft tissue sarcomas, the application is wide and much more useful. Thank you everybody for your patient attention.